Fucker. Yeah, everything was missing. What would you do? Like a stew? Right?
Alright, so we're starting Journal Club. Today is August 26th. We have a couple of things to go over. We're not having Journal Club next week because of the holiday. And who wants to get started with interesting cases?
All right, so yeah, we had one last week. We had a guy who was actually entrapped. He was caught under a forklift, so it seems like he was unloading a trailer and was walking behind another operator of the forklift and wasn't seen by that operator, so kind of fell down and then got his leg caught under. So I think the call went out around 1:30. PD got on scene first. They applied the tourniquet because they noticed that there was some blood loss, and the tourniquet was applied at 1:38. They called the physician response, and we got there in about 22 minutes, I think, and was actually able to get the guy's leg free. So we did a couple of things. We tried multiple times with, just actually like ultrasound gel and actually some dish soap to kind of lubricate and see if that would open up the or create enough, decrease the friction so that we could just pull the leg out. Really didn't help. So then they actually tried to use the jaws of life to see if they could separate the two wheels of the forklift. And I think what ended up happening is, as they were opening one side, the other side was kind of compressing in. Again, he didn't tolerate that, so we made the decision to actually just do a conscious sedation. We used ketamine and put him out, was able to actually just take the leg down with just force, and was able to get him out, and did pretty well, actually. Because of blood loss, he was becoming tachycardic. We ended up actually transfusing him. It was really hard to estimate how much blood loss he had because it was in the back of a trailer that had some wood or wooden slats. So, and there was spaces, so
You can't even tell how much.
exactly. And then
So notoriously, blood loss is very difficult. I mean, one way that you can try and do it is a lot of people just take a 2-liter bottle of soda. It's fairly easy to find, and you just throw it on the floor, and you kind of see, okay, if someone lost 2 liters, this is what it would look like. And every single time you pour 2 liters out, it looks different.
Right.
So.
Right. And we actually ended up flying the gentleman out, and when the flight crew got there, just because
Did you intubate?
we did, we actually intubated, only because his mental status was kind of waxing and waning. Again, I think it was probably more so from the sedation, but the flight crew was concerned with transport and the questionable mental status that it was easier for us to just intubate, which is what we did.
So many reasons can cause the altered mental status.
Exactly.
It could be from the acute blood loss.
Right.
It could be from the shock,
Right.
shock of like having your leg almost taken off.
Exactly.
And a lot of the times, like you were saying, that the problem was the pain that the patient was in.
Right.
So this happens a lot in car accidents. The brake is one of the strongest pieces of metal in the car, and somehow that leg always gets stuck underneath the brake.
Right.
So usually what I think about when I see a case like this is, okay, is a patient stable or not stable?
Right.
If they're stable, we have time. Let rescue do their work. They train for this. Let them do whatever they need to. What I want in the meantime is to make sure that the airway is patent, and if it isn't, how am I going to secure that? Also, IV access.
Right.
How am I, do I put an EJ in? Do I get a peripheral line? things along those lines. Do I just drop an IO just
Right.
so I have access to push drugs if I should need it?
Right. So luckily, he was a pretty young guy. He had great veins, so we had great peripheral access, so it wasn't an issue. I think between the time of how long he was in the back of this really hot trailer and the pain and each attempt, he was becoming more anxious. It was just a lot easier to just do the sedation and kind of free him up and kind of get him going from there. So everybody did a great job, I think. We did have some follow-up, Dan.
Yeah, so the patient actually ended up doing quite well. Still in the hospital, the last I heard, but the wound is healing. The leg is still viable and should remain so.
And that's the most important thing. We want to preserve life and limb. Unfortunately, sometimes we have to take the limb, but this was not one of those cases. So definitely a great thing. Also, whether or not to land a helicopter or not land a helicopter, that's something that is based on at the state level, at the agency level, and even at the local level. Because in our eyes, something might be very close by ground, but depending on traffic patterns and things like that, it could be a difference of life and death, getting there that much quicker. So I usually leave it up to whoever knows the area to kind of make those decisions.
And that's exactly what we did.
That's a good case. I mean, similar cases, industrial accidents. One of the biggest thing is I'll push procedural sedation and I'll just yank on it really hard. Because just like when we started, I don't know about you guys, but when I started doing IVs, one of the biggest things when I started doing IVs was when the patient starts to scream, like I kind of pull back a little bit, So like I would always miss those IVs. It wasn't until I'm just like, okay, I'm just going to start this IV that, So when you're pulling on someone's leg that's possibly hemorrhaging, but it sounded like the tourniquet handled it very well. I usually will put 2 tourniquets on the leg, just because of the size and location. But if one tourniquet's working, just leave it. And remember, what a lot of people don't do is, when you put the tourniquet on, you want to make sure it's tight to begin with before you start using that windlass. And that's one thing that we talked about last week with the journal club, was that if you just gave someone a tourniquet, most people can't figure out how to use it, and especially in a stressful situation. I actually saw something very interesting. They were using a pool noodle as a adjunct, as like a leg, right? And then they put some sort of tubing through it, hooked up to a bag to represent hemorrhage. And then you have to kind of tighten down the tourniquet to stop the bleeding. I thought that was innovative and interesting. I'm sure people have been doing it for years and I just never heard about it, or I just forgot I heard about it. But that seems like a good way to train. Because one of the big things that we found is that people who were using tourniquets on themselves or on colleagues, they would either not tighten it tight enough to stop bleeding, or because of muscle memory, during training they'll tighten it tight enough, but then they'll loosen it. And then when they come into an actual either tactical situation or a hemorrhage situation, they would just loosen it automatically because they're not thinking, because that's how they trained. Similar with the nasopharyngeal airwaves, instead of putting nasopharyngeal airwaves in patients, they would just tape to the side of the face. So people would get patients with nasopharyngeal airways taped to the side of their face in real life situations, because you're not thinking, you're just doing muscle memory. So you have to train as if it were real. Any other interesting cases?
Another one that I ended up taking a medical about was a patient that paramedics got to the scene and found him to be bleeding from a wound on the abdominal wall. Not a traumatic wound, however, a hernia that had opened up and was bleeding pretty significantly. The patient was awake but altered, had apparently some alcohol history, that kind of thing. So there was concern that he was not going to clot very well to begin with. They ended up getting IV access on this gentleman. Fortunately, the house was a bit of a difficult time for them to get to the person. Paramedics called me for orders and actually were able to utilize FaceTime to show me the wound and how significant the bleeding was for this patient. Thankfully, after direct pressure, which is always our simple go-to to stop bleeding, and a couple of grams of TXA, the patient was able to, they were able to get the bleeding to stop, get the patient transported over to the hospital, and also follow up on that gentleman. He is still stable and doing well here in the hospital now.
Yeah, post-surgical bleeding is, one of the things we always talk about, but, how often does it really happen? And then how do you control that, especially, was this like at a junction? Like, where was the hernia?
Turns out it was an umbilical hernia
Okay.
that had just opened up.
So-
It had not yet been repaired.
So difficult to compress, especially because you're pushing against the abdomen. But, the first thing I always say is, try and find the bleeder and put one finger on it, and try to stop it. And the TXA, great use of TXA. And then, if I was in the field, would I be able to just kind of whip stitch this or do something to kind of stop the bleeding beforehand? Shall we go to the articles?
Sure.
So I'll do the Heaven criteria article. So this is basically a difficult airway assessment tool. The ones that we normally have are Lemon and the Mallampati score, but as everyone knows, they actually have to be awake to do. They actually have to be awake to do this. How many times do we try to chart and they want a Mallampati score and the patient's unconscious? But with the Heaven criteria, also with the Mallampati and the Lemon criteria, what it does, it only takes into account the anatomy, as opposed to the Heaven criteria, which takes into account what's actually going on with the patient. So the Heaven criteria itself, it is hypoxemia. Do they have an oxygen saturation that's less than 93%? Extremes of size. Are they pediatric patients? Are they obese? Are they older? Any type of challenges in their anatomy that you would think. Do they have a trauma? Do they have a small neck and everything like that? Do you see any vomiting, blood fluid? Have they been bleeding, whether it be chronic or acute? And this could kind of raise concerns as to how much oxygenation you actually have. And then do they have any issues with their neck? So these are especially in trauma patients. So what they hypothesize is that the total number of Heaven criteria is inversely proportional to the success for first attempt intubation success without any oxygen saturation. So this is a retrospective analysis study done by the Air Methods Airway Registry, which includes 160 medical bases across the United States. So for all non-arrest patients, they would utilize an RSI technique, as well as do pre-oxygenation and passive oxygenation with a non-rebreather or BVM. And then they applied the Heaven criteria to assess how difficult the airway will be. And the way that they confirmed tracheal positioning was through waveform capnography. They included subjects that had RSI completed, had a Heaven criteria completed, and also had a Cormack-Lehan criteria completed as well, and whether they completed if the airway was successful or not. This was done over a 24-month period, and what they were looking for specifically was 2 outcome measures, which were used to define intubation. Either be failure to place a tracheal tube on the first attempt, or failure to place a tracheal tube without any oxygen desaturation, so dropping below 90. They included ultimately 5,137 patients in the study. For tracheal intubation, was successful in about 4,970, so about 97%, and was successful in the first attempt in about 91%, without any desaturation. So the percentage of patients that had a difficult airway view was statistically significantly higher if they had a presence of each of the Heaven criteria with both direct and video laryngoscopy. In first attempt intubation success was lower if they had a presence of a Heaven criteria in both direct and video. And they also had a statistically significant independent association observed between individual Heaven criteria and a failure to intubate on the first attempt, with the exception of hypoxemia and exsanguination. So ultimately, the discussion goes on to compare the different Malampati's, Lemons, and the Heaven criteria, and really when to use laryngoscopy. But ultimately, what the study shows is that using the Heaven criteria, the more Heaven criteria you have, the chances that your first pass success is going to be lower compared to if you had if you had 0 to 1 Heaven criteria. I like it's a better than Malampati and Lemon because most of our patients are unconscious anyways, and I'm not going to tell them to open their mouth to check their Malampati score. But the problem is most of our procedure logs have documented Malampati score, which I usually say that we are unable to.
And most of like procedural sedation or modern sedation stuff require you to put in these scores. We talked about this earlier today during our didactics, but for me, every airway is a difficult airway. I don't care really what your running score is. I'm treating it as, there's a possibility this is going to be a failed airway. I prep the neck and I think about where am I going to cut. I'm thinking about what my backup is going to be before it happens, because everyone who you talk to about a surgical airway, or they had to go to their secondary airway, the thing that they always say is that it should have been earlier. It's not when I should do this procedure. It's okay if after the second expert attempt it doesn't work, we're going to start to do a surgical right. If this doesn't happen, then the senior person is going to take another shot, and if they can't get it on the first try, we're going to go to surgical. Because it's thinking like, oh, should I do it? Should I not do it? It's way too late. All right. Next.
I'll go really quickly. I'll grab. Sorry, I think that ours is on battery. So my article was pre-hospital advanced airway management for adults with hospital cardiac arrest. It's a nationwide cohort study. This was published February 2019. So just a little bit of background. There's previous observational studies discussing pre-hospital advanced airway management by EMS personnel, and it was essentially said these previous studies said that it was associated with worse outcome. But the distinction these authors wanted to make was that previous studies, they used traditional propensity score matching, which I'll talk about a little bit further. But essentially, their clinical question was to determine survival associated with advanced airway management. Specifically, their definition of advanced airway management was a supraglottic airway, or ET tube, compared with no advanced airway for adults with out-of-hospital cardiac arrest. So this study was a cohort study, January 2014 to December 2016, out-of-hospital cardiac arrest, separated into two cohorts by the first EKG documented, shockable rhythms versus non-shockable, and this was all done in Japan, where they have a nationwide collective kind of patient information. So, and in their study, they sequentially matched patients with advanced airway management with patients at risk for advanced airway management. And also, they talk a little bit about resuscitation time bias, which essentially means patients undergoing longer resuscitation tend to receive more interventions. So they used in this study they used time-dependent propensity scores to sequentially match and kind of essentially take out some of that randomization. So their inclusion-exclusion criteria, criteria was out of hospital cardiac arrest between January 2014, December 2016, 18 years or older cardiac arrest before arrival of EMS personnel, cardiac arrest for which EMS personnel attempted CPR, and cardiac arrest attended by an EMS emergency life-saving technician. The exclusion was older than 120 years, unknown first documented EKG, missing or contradictory data, and time from call to CPR by EMS personnel was 30 minutes or more. Specifically in this study, their primary and secondary outcomes were survival at 1 month or at hospital discharge within 1 month, and their secondary outcomes were functional outcomes determined by the cerebral performance category scales. Specifically, they wanted one or two, which was good cerebral performance and moderate cerebral disability, with 5 being brain dead, 4 being coma, and then 3 being severe cerebral disability. So essentially, they kind of broke out their results into two kind of groups. Essentially, they kind of gave out their first results without the time matching, and in that, advanced airway management was associated with worse survival in both rhythm cohorts, the non-shockable and shockable, which kind of reiterated what the previous studies had said. But then when they sequentially matched the cohort, meaning they take a little bit of the randomization out of it, in speaking with, so when all that was done, they essentially had 16,000 in the shockable cohort and 236,042 people in the non-shockable cohorts were matched, specifically with time. And in their outcomes in the matched cohort of shockable rhythms, survival did not differ between patients who received advanced airway and those who did not receive advanced airway. But in patients with sequentially matched cohort of non-shockable rhythms, so patients with advanced airway management had greater survival, 2.3% to 1.8%, when compared to people who did not have advanced airway management. So essentially, what they're saying, the results they're saying is that in people with shockable rhythm, you should immediately defibrillate and continue CPR. But in people with non-shockable rhythm, they would benefit from advanced airway management, and that's essentially what they. So this is a little bit of new twist in the previous research. I think it was a good study. They talk about a little bit about their weaknesses, but overall it was a nationwide registry, complete data, no missing information, large sample size. They had a lot of strengths, so overall I thought it was a good study and a good conclusion.
Thanks, Eric. Does anyone have anything to say about that?
I mean, I think it makes sense. If you have a shockable rhythm, the first thing the biggest thing to do is, defibrillate and try to get them out of that into a perfusing rhythm. So the patients with the non-shockable rhythms, you have other causes, which could be the hypoxia is one of the H's or whatever, and so establishing some sort of airway to control that or to correct that.
Yeah, in general,
Makes
what we
sense.
do naturally, not even thinking about it, is, put them on oxygen, start an IV line, give some fluids. These are things that kind of knock things off the list.
Right.
Unfortunately, the more we protocolize things, the less brain power it takes, and the more that we can apply to actually figure out what's really going on.
So I'm going to talk about the 3 airway management technique for airway decontamination and massive emesis. So this was a study that was done with anesthesiology and emergency medicine residents. They randomized them into 3 different arms. They looked at a traditional airway decon technique, an IEI or intentional esophageal intubation technique, or SALAD, which was the suction-assisted laryngoscopy airway decontamination. So they were trying to look at a primary outcome of how much aspiration volume was actually collected in the lower airway of the mannequin. Should be consistent with the amount that actually would be aspirated into the mannequin airway. A secondary outcome they were looking at was successful intubation attempts, and how long it took them to actually intubate the mannequin. So they utilized a mannequin that had a setup to where they could actually pump massive amounts of simulated emesis into the airway while intubation was being performed. The 3 different techniques that were being compared was the traditional, which they defined as positioning the patient in a head-down position. You would decontaminate the airway by suctioning and then intubate either with DL or VL, as traditionally was done. They compared those to 2 alternatives, the intentional esophageal intubation and the SALAD or suction-assisted laryngoscopic airway decontamination technique. So the SALAD technique was actually going in with the suction device and the laryngoscope, suctioning as you go, kind of using it as a tongue depressor, and then once the glottis was observed, kind of moving it over to the left side and holding it in the same hand as laryngoscope and holding it there at the same time while you're trying to intubate. That frees up that right hand to actually place the tube. The intentional esophageal technique was actually just blindly intubating with the ET tube, and if it happened to end up after inflating the cuff in the esophagus, that would hopefully control the vomit and shunt it away to where you could then follow along with actual intubation. So they basically just kind of randomized these residents into the different arms, and their results they found was that the time to intubation was similar, as well as their primary outcome, which is the quantity of volume that was still collected in the airways were similar. They came out with 72 milliliters, 100 milliliters, and 83 millimeters in the 3 different arms. Intubation success they claimed to be 100% in all groups, and this was made up of varying levels of PGY 2-3s, different levels of the actual PGY 2-3s and 4s were actually utilized in this. They basically felt like their conclusion that they had similar performances with all 3 of these to control the airway, and that either one could actually be used. They did actually find that they didn't have enough number of actual residents due to lack of interest and just participants to actually meet the power for their study. There was also some comments about the different compliance in the airway of the mannequin, and that it might not have given a full reflection on how much aspirate would have actually taken place in a true patient. But I think overall it was an interesting study to kind of show that, all 3 of these techniques probably have similar outcomes. There was, comments that actual aspiration during or emesis during intubation or during RSI was 0 to 33% or 0 to 22%. So it had a large range of how much actual emesis occurs during RSI, but I think you could also apply this to just hematoemesis or any kind of situation where you just have a lot of airway contamination in general when you're trying to intubate.
Yeah, I know the old teaching was always to just kind of hold your breath while you're suctioning them so that you don't suction too long. I find that that's not a great idea. Sometimes, the rigid Yankauers have that hole where you have to occlude. Some people forget to do that. Some of the rigid suction catheters don't even have that. You have to be familiar with your equipment. The other thing is just using some of the supraglottic devices now have suction built in, which is very helpful. I know that in the past they've also had the system where you can kind of jerry-rig your laryngoscope blade so it has suction built in plus a little washer with saline. But if I had enough time to do that, it wouldn't be difficult. You know, I mean, I've never had that much time. You know, I guess you could do it at the beginning of your shift, but I don't know. So massive decontamination. I mean, sometimes it's just turning them over and letting them drip all the way out. Do you want to try one more article and then we'll call it a day?
So I did the guiding CPR with 5 focused echo case. There are 5 cases basically. Kind of a spoiler alert that none of these patients actually had good outcomes, and none of them had bystander CPR, which probably related to why they're not having good outcomes. So, but it was good cases showing basically what the effect of a focused echo will do. So they're basically saying that the benefits of these focused echo done in cardiac arrest are to ID the reversible causes. So I'll just kind of quickly go through the 5 cases. So the first case was a 45-year-old male found unresponsive 30 minutes after last seen. ALS got there within 6 minutes of the scene. Started mechanical CPR, with a bag valve mask. No bystander CPR. The initial rhythm was a PEA. They gave Narcan, and they intubated. At that time, the end tidal was 18, and showing SpO2 of about 55%. Upon arrival to the ED, the physician used a peristernal long axis to kind of see that the compressions were not over the right part of the heart, so they moved it more, so it was more over the left ventricle, and the end tidal jumped up to 68 from the initial 16. Eventually, then was found to be in a fine VFib, was shocked, and they got ROSC, but a few days later, they basically found out that he had global hypoxic encephalopathy, and the family withdrew care. So the second case was 84-year-old female, unresponsive. They did hear a fall. There was no bystander CPR. ALS came. The patient was in VFib. They shocked, gave epi, calcium, bicarb, intubation, and mechanical CPR. 20 minutes to the hospital. In the ED, they found the patient was in asystole with 65% SpO2 and end tidal of 13. They had a right main stem intubation, which was fixed, increased the oxygen. They also used the peristernal long axis on the ultrasound and found the mechanical CPR was over the right heart and the aorta, so they moved it over the left ventricle, which increased the SpO2 to 100 and increased the end tidal to 42. They briefly got some organized cardiac activity, but the family withdrew care, so they stopped CPR. The third case was a 54-year-old male, COPD, called for shortness of breath. Himself, found in PEA by ALS. They put in a supraglottic airway, started CPR, gave epi, calcium, bicarb, and then about 20 minutes of CPR to the emergency department. They found the SpO2 was 40%, end tidal of 8. Again, the peristernal long axis was utilized. There was no LV compression, so they moved it, and that increased the SpO2 to 90 and the end tidal of 40. This patient ended up having intermittent VTAC, but also succumbed to their arrest. Case 4 was a 74-year-old female, hypertension, diabetes, CAD, complaining of a headache, dizziness, and shortness of breath. This patient actually was witnessed unresponsiveness. ALS found her in PEA. There was no bystander CPR. Once they got there, they started manual CPR, epi, bicarb, and amio was given. They got ROSC. They found this patient had a STEMI. 15 minutes after they arrived to the ED, they lost pulses, and CPR was started again. End tidal was around 16 then. They used a parasternal short axis and moved it, which they got ROSC immediately, and the end tidal jumped up to 57. They recoded a couple more times, and then basically family actually terminated resuscitation. The last case was a 72-year-old female, hypertension, basically complaining of chest pain, shortness of breath, witness collapse. There was, again, no bystander CPR. ALS came, found that the patient was in VFib, started mechanical CPR, intubated epi, and shocked the patient. In the emergency department, they found, this time using the subxiphoid approach, they found that the mechanical CPR device was in the right place, but there was a large pericardial clot, as well as the patient was having VFib with tamponade, so they did pericardiocentesis, got 60 cc's out, and they got ROSC. After that, they used the parasternal long axis to see that there was a dilated aorta, so probably an aneurysm or dissection causing this pericardial fluid to accumulate. They did get this patient to the CT, and they found it was basically a ruptured ascending aorta. And they, I guess because of age, they said this patient was not a surgical candidate, and the family withdrew care. So overall, I think this is good at definitely showing that we should be doing ultrasound on all these cardiac arrests. I think the type of view that we use is very subjective. I know myself, I like to use the subxiphoid a lot, but that's also really hard if you have these like really distended abdomens, or if somehow it's like obstructing your view for subxiphoid, because also if you have these like mechanical advantage or the mechanical CPR devices and everything going on in the chest, it's kind of harder to do like the parasternal long axis. They do recommend that you can use kind of modified approaches, so either like a modified apical 4-chamber, or like a weird modified parasternal axis as well. But this also kind of leads us into the use of TE that we started using, but might be better in the future because you're kind of out of the way of everything.
Yeah, absolutely. So the push right now is to start doing transesophageal echoes. What all these cases, the reoccurring thing was, first of all, it was transthoracic, which is more obtainable, especially in the pre-hospital setting right now. And it seemed like I prefer to do the 4-chamber view, which is kind of like on the lower left axial area, and mostly because of the fact that I'm not interrupting compressions. The reoccurring themes about all these cases were that, one, there wasn't good bystander CPR. That's what we know, that, you know, if I could invest money in anything, it would be getting more people to do CPR before I get there. Because if the person's already hypoxic brain injury, or they're already gone before you get there, you have nothing to work with. That's the reason why a lot of our CPR and cardiac arrest data is so skewed, is because, you know, how many of these people were viable when we got there. So I could have the best care ever, like top of the line, restart everything. But if there's already hypoxic injury before I even get there, there's nothing to work with. The other thing, the recurring thing I was hearing, is that they were moving the compressions over, so that's actually over the ventricle. Big thing. You know, we see it all the time because we do chest x-rays on patients in the emergency room, but how often is the left ventricle right underneath the sternal border? It's like very rarely. But we need to start somewhere, you know? The other thing is, for those of you who have done the TEEs, you know, it's so easy. Like, you get it in the right depth, and it just comes into view. And then with a small flick of your wrist, a small adjustment, you have your other views. And it just makes such a big difference. For guiding CPR, a lot of the times, you know, they didn't mention it in this article, but I know from our personal experiences, we find that, you know, patients who we feel a pulse, or we say, you know, we'll talk about this another time because it's another one of the articles for maybe the next time we meet, but PEA. You know, is this a narrow complex PEA or a wide complex PEA? And if it's a narrow complex PEA, is it actually PEA, or is it that you just can't feel the pulse? Is the blood pressure so low? You know, from those of you who have done, you know, rotations in CCU or even in the ER, if we drop an arterial line and we actually see their waveform, sometimes it's like, well, I can't feel a pulse, but I can see a pulse. So let me start an epi drip, and the epi drip brings their blood pressure up, and then, you know, they're no longer in cardiac arrest. I've shown up to scenes where, you know, people have been ready to just call it, and, you know, I take a look, I see that there's a good contraction of the heart, and I start an epi drip. I stop CPR because the CPR may or may not be helping, but, you know, as soon as I get that epi drip shot, you know, I stop CPR, because even if the blood pressure is too low, CPR may help to kind of help move some more blood, but really what's going to help is increasing that blood pressure. And then lo and behold, suddenly we have a blood pressure, we feel a pulse, and then, you know, we get back to that same thing. Well, how long were they down before we got there? Was there bystander CPR? You know, we talk about this all the time, but this is one of those big things. You know, what are the things that give good outcome? You know, shockable rhythm, end tidal, you know, at a good level, bystander CPR. What else? What are the other two?
Yeah, initial shock aware.
So those are kind of the big things. We're gonna wrap it up unless anyone has any more comments about this. But like, I'm big into the, you know, ultrasound. I want to get ultrasound in everyone's hands because, especially in this case, you know, you can see quickly is the patient volume depleted? Are their lungs up? You know, are you having pericardial effusion? You were talking about they pulled out 60 cc's. You know, on a patient who has, you know, normally physiologically less than 5, less than 10, you know, 60 cc's is compressing the heart. Mm-hmm. You know, but you could also have someone who just built up in the long term, and 60 cc's may mean nothing. But the fact that you tapped it and, you know, you got ROS right away, that says something. Yeah. Now with the clot, you know, whether or not to push TPA is another thought, but, you know, with a suspected aortic aneurysm that's already ruptured, like, that is not a TPA candidate. Like, so, you know, we have to kind of balance all these different things, and we have to think about it.
Are you guys a big fan of putting like a triple lumen in if you see that, if you have a suspected where you need to keep drawing blood off? Like
So what Dr. Goltz is asking is, do we put a catheter into the pericardial space to continue to withdraw fluid from the heart? I mean, I'm a fan of pericardial window, but again, we can't do that pre-hospitally, nor can we do that in the ER. That's done in the operating room. But, you know, if needed, yeah. You know, pericardial tamponade, pericardial fusion drainage is a little less scary now that we don't do it blind, that we do it with an ultrasound machine. So you can, like, okay, let me see where my biggest pocket is. Let me see where I'm not gonna, you know, cause pneumothorax while I'm doing this. You know, it's much more helpful now that we have ultrasound. But there's still people who they've been doing it, you know, subxiphoid approach, angle it up, hit it, take out the blood, and then move on. Yeah, it's just like before our time. You know, lots of people, they would do blind IJs. They start central lines or blindly, but now with ultrasound, it's almost unheard of. There are cases where it's an emergent situation where there's no ultrasound machine available. So that's why when I teach people how to do lines, that before you use the ultrasound, think about where you're going to go, how you're going to position, and then, you know, okay, I would stick my needle here, and then, okay, so put the ultrasound just below that, and now think about, okay, would I have hit it? Would I have transected the artery as I'm trying to get to the vein? I mean, these are things that probably happened all the time before, but now that we have a better method, we should try and use the better method. All right, so that's it for Journal Club this week. We're skipping next week because of the holiday, and then we'll start up again September 9th.